Oh, thank you everyone for joining us for our second Lunch and Learn. I am Saqib Bhatti. I'm the uh, Executive Director of the Action Center on Race and the Economy and Bargaining for the Common Good. Uh, we're proud to be hosting this event and really, really excited to have uh, two wonderful speakers here, Alexandra Nam from Generation Patient and Tahir Amin from I-MAK. Um, as y'all know, the where this really sort of started, the Lunch and Learn series, is that Robert Wood Johnson Foundation commissioned a series of research on the financialization of healthcare, and we're using this Lunch and Learn series as starting off for it is basically doing presentations of different pieces of the research. And the one that I-MAK did is really focused on uh, patents for GLP-1 diabetes drugs and the impact that's had on access for communities of color. And so we'll turn it over to them in a minute. But before, I wanted to introduce Malini Kadambi Daniel, who we just brought on as our Senior Director of Healthcare Organizing at ACRE and Bargaining for the Common Good. And she's going to be leading the healthcare work for us going forward. So I wanted to hand off to her.
Thanks, Saqib. I'm very excited to be here. So I will just give a very quick agenda overview of this presentation. We will hear from Generation Patient and I-MAK. They've got really good, just great stories, and the great work that they're doing around health, our equity is just going to be fascinating. We'll do some panel questions, and then we'll hear from you and your questions. So you should feel free to drop questions in the chat and we'll collect them towards the end and ask our speakers your questions. So just to give a very quick bio on both of our presenters, Tahir Amin is a co-founder and co-executive director of I-MAK, which is the Initiative for Medicine and Knowledge. He is an intellectual property lawyer by training and left private practice, moved to India and became involved in working with marginalized communities there and NGOs. I-MAK takes his expertise and puts them in service for fighting for equity in the drug patent system. Alexander Nam is a policy manager at Generation Patient. He's another lawyer by training. Alexander's personal experience with having a rare genetic disorder led him to work in healthcare equity issues. Generation Patient supports young adults with chronic and congenital conditions through community building and advocacy. So we'll let them get started. And if folks want to, feel free to drop in the chat why you are here, but I will turn it over to Alexander right now.
Thank you so much for the introduction and for the opportunity to speak with you all today. I'm really excited to be here. My name is Alexander Nam. My pronouns are he, him, and I'm the policy manager at Generation Patient, an advocacy organization representing the over 25 million young adults living with chronic and rare conditions. I want to take some time today just to share with you all my personal experience as a patient. I was born with tuberous sclerosis, or for short, TSC. TSC is a rare genetic condition affecting a very small percentage of the population, with approximately 50,000 people in the US currently living with TSC. But for myself and many family members, it caused me to be born with non-cancerous tumors throughout my brain and skin tissue. I was in middle school when an MRI of my brain revealed several tumors throughout it. In this initial observation of these tumors, the physicians I interacted with were unsure what was causing them, and cancer was not ruled out. This was obviously very difficult for my parents to hear, and my mom spent a tremendous amount of effort to get a better understanding of what was causing these tumors, especially because of my family history with epilepsy and brain tumors. After meeting with specialist after specialist, we were finally able to find a neurologist who was aware of our condition and was able to receive a diagnosis of TSC. It goes without saying that managing TSC can be very financially challenging. Growing up, my family struggled to obtain insurance coverage for the medically necessary testing and surveillance needed for our condition, facing many denials, failed appeals, and long-lasting medical debt. The surveillance of our neurological system didn't end in my childhood. It's a lifelong effort. As I age, there's a 1 in 4 chance that the tumors will begin to grow, requiring the use of medication in the form of mTOR inhibitors to control the growth. as well as other medication to control the secondary neurological symptoms emerging from their growth, which can include medication for epilepsy, a symptom that many of my family members already experience as a result of their TSC. With the high financial burden already associated with managing TSC, having access to affordable generics is key for me and my family's survival as we navigate and control the changes and symptoms that emerge from our genetic disorder. And while me and my family's experience managing our TSC has been difficult, I do want to acknowledge the race and class privilege that me and my family possess that have allowed us to, one, obtain a diagnosis for a rare condition, something that required immense patience and interacting with different physicians until we were lucky enough to find an expert who studies our condition, as well as two, afford to pay for the medications needed to control the symptoms of our condition. For many patients who are Black, Indigenous, and other people of color, there are many barriers that exist that prevent them from accessing the care and medications they need to ensure their survival, especially when you factor in the current and past history of institutional injustices and medical racism that disproportionately affect these communities. For example, many of our community members from BIPOC communities have expressed fears in communicating with their physician because of experiences they've had with both implicit and explicit bias with other providers. These experiences include medical gaslighting, or not having symptoms taken seriously, or a physician underestimating the pain being experienced by the patient, but it can also include stereotypes directed towards health behaviors, including diet or social environment, as well as overall less patient-centered communication between the provider and the patient. This erosion of trust makes it difficult for patients from BIPOC communities to advocate for themselves in the doctor's office, especially if a patient wants to switch from their high-priced medication to a cheaper generic that is now available. However, for many patients, the opportunity to access a cheaper generic medication isn't even an option, especially for patients living with diabetes who need to access a semaglutide to manage their condition. A condition that disproportionately impacts BIPOC communities, with the U.S. Health and Human Services reporting that Latinx patients are diagnosed with diabetes at a rate 13% higher than the total adult population, and Black patients at a rate 24% higher than the total adult population. Unfortunately, semaglutides like Ozempic are unaffordable for most patients, with a month's supply being as high as $1,304 in cost. And even with potential manufacturer discounts lowering the monthly cost to $499, this is still immensely unaffordable for many patients. And the other approved semaglutides, including Wegovy and Rembulis, presents patients with the same unaffordable monthly cost. These issues surrounding GLP-1 access brings up another issue that many BIPOC community members have expressed, which is the growing number of pharmaceutical advertisements being directed towards them on social media. Often these ads utilize personal data collected from patients as they engage with social media applications, including Instagram and TikTok, in order to target these patients with personalized advertisements. Many of these ads are focused on influencing patients to select high-priced brand name medications, even in instances where cheaper generics are available. Some of our community members have even sent us examples of ads that provide scripts on how to engage with your physician to make them prescribe a particular medication. These patient scripts were created to exploit a very real fear that patients in BIPOC communities have in connecting with their physicians. But rather than helping the patient navigate a broken healthcare system, these scripts are tricking patients into receiving a higher price medication. Further, there's been a rise in advertisements that redirect patients to telehealth platforms, something that on its face would appear to be beneficial, because it can help patients, avoid the stresses that come with in-person interactions with physicians. However, these telehealth platforms have been shown to be completely funded by brand name manufacturers, with physicians who are financially incentivized to push high-priced medications onto patients. And these disparities only increase when you factor other intersectional identities, including sexuality, gender, and age. For age specifically, young adults experience the highest rates of poverty and uninsurance when compared to all other age groups. As young adults, we are in a time of great change and transition. We're focusing on our education and building our identities. Some are even focused on building their families and ensuring their children's future. Now imagine having to deal with these challenges while also managing your chronic condition. It's an impossible challenge, especially if you're having to pay for a high-priced medication that lacks a generic alternative. Many young adults living with chronic conditions are forced to decide on managing today's health or ensuring a successful tomorrow. But for many, the decision's already made for us, because unfortunately, tomorrow won't come if our health isn't handled today.
Thank you so much, Alexander. That was amazing. I actually was a little bit astounded because I'd never put together the social media piece of it and how folks are being targeted. So that's really actually quite interesting, and I'd love to dig in a little bit more later. I am going to turn it over to Tahir Amin.
Yeah, thank you, and thank you to Aka for hosting this lunch and learn. I've learned so much from the last one, and just listening to Alexander, even though I know some of Generation Patient's work, I've just learned a whole bunch more. So thank you for that, Alexander. It really is just really shows why we do this work and what we're up against in trying to address many of the systemic problems. Which is I'm going to shift the conversation to speak about, well, how are drug prices so high, and really connecting the issue of financialization, which is one of the research areas that we were tasked with through the RWJ work, to connect it to sort of the patent system. A lot of the time we read about financialization, at least from my perspective, it's talking about shareholder buybacks, the dividends, and how the financial sector is driving pharmaceutical or sort of non-financial corporation behavior. But rarely do we speak about it in terms of, well, what are the tools that companies use in order to extend their monopolies to keep these prices high? And as somebody who's worked around the world on these issues, we're focused largely on the issue of the intellectual property system, which is patents, particularly when it comes to medicines, and how they actually allow pharmaceutical companies to maintain these revenue models that keep drug prices high, that keep competition off. And I think it's an important part of the work that we all need to develop to, because patents are a bit of an obscure technocratic system that not many people encounter. And I hope through this discussion today and what I'm going to present will at least bring people more into awareness of some of the issues at play. But before I do that, I'd like to just take a step back and just take a broader view of what's going on in the healthcare space and prescription medicine space. We just did a survey which is going to be launched next week, and we'll share the webinar details. But based on this, it was a national survey, bipartisan amongst different communities. It was run by the Franklin Marshall Opinion Center, so it wasn't done by us. And some of the statistics that came out of there repeat research results that groups like the Kaiser Family Foundation have released a few years ago. Basically, among 71% of adults who reported taking prescription medicines in the past year, 31% didn't actually fill the prescriptions due to cost. 58% of drug users that were interviewed employed desperate strategies, such as skipping or delaying prescriptions in order to reduce expenses. And a lot of the response were actually women and lower income families that are hit the hardest. Now, of course, we know the BIPOC community is probably on the lower income side of things, and so they're the ones who are probably going to hit the hardest. But what we also found was, and I think this is something that we hope to message with policymakers, is that 84% of those interviewed believe pharmaceutical companies make too much profit. And 61% of those attribute high drug prices to pharmaceutical company greed and profit-seeking behavior, which is very much speaks to this whole business of financialization and the way the industry has developed over the last 40, 50 years. But what was also surprising to us, and now I'm going to bring it to the patent situation, was 4 in 5 Americans, when asked, support changes in the patent laws to address high prices. And that was actually greater support than actually direct government price controls. So that's quite telling because, as many of you may be aware or not aware, most people think patents are sacrosanct, the greatest thing since sliced bread, and basically messing with that system is going to harm, quote unquote, this ubiquitous term that I prefer not to use, but it's the innovation sort of system. And we wouldn't get all these medicines as a result. So basically, just setting that up and bringing patents to the fore. Again, I know we have many people here who maybe not versed with these issues, but just to kind of get some sense of where you are in this conversation, how many people think that there's just one patent on a drug? And just a show of hands, or you can put it in the chat. Just want to get a sense of where. Okay. How many think that there's between 5 and 10 on a drug? Um, so I'm trying to see the chat if anyone's speaking in the chat. How many think maybe between 20 and 50? What about over 100? Anybody who's taking that? I'm sorry, I don't have any prizes to award at the end of this, so it's all voluntary. Um, Great. Okay. I asked that question largely because there is a general perception, and I think Sakib, when we were chatting about preparing for this call, there's a general perception that, yeah, there's just one patent on a drug, and you have a period of time, which is usually at this moment in time, it's 20 years from your date of filing of a patent. And then once that ends, that's it, the game's over. Well, that is actually not how the system has evolved. And this is where I think where we get to the conversation of how financialization has basically also financialize the patent system, because the patent system is a great tool for the pharmaceutical industry to make all these super tweaks to an existing product in order to life cycle manage the product to keep the prices higher and to keep competition out, and so that they can actually hit their revenue targets and keep the wolves of Wall Street happy in their quarterly reports. And that's pretty much how the system has developed. And there may be nuances to that, but that is pretty much how the patent system has developed, at least from somebody who is a patent practitioner. An economist might say, well, they're doing innovation. I would completely disagree with that, because this is where I think economists and lawyers need to actually huddle together and speak the same language, because they don't. Economists are interested in utility. So if I make a slight improvement, then great. They think they should get a patent because it's useful to society. But actually, if they reinventing the same knowledge, so to speak, and actually privatizing public knowledge, common knowledge, then why should they get that monopoly again? And I think that is where the disconnect happens between the sort of neoliberal economics that dominate this place now, and actually what those of us who are practitioners in the law actually feel that there's a real disconnect. And I just want to use an example before I get to the GLP scenario of there's a drug called Humira, which actually used to be the best-selling drug. And Jessica, if I may bring up the slide now, thank you. This was a New York Times story that ran a couple of years ago. We spend a lot of time researching this drug, Humira. It's for rheumatoid arthritis, and it has various other conditions. So this brings me back to that point where you think, you get one patent for a drug that you've discovered. Well, what AbbVie was able to do, because there's several conditions that you can treat with this, it's the same mechanism of action. So they could treat it for rheumatoid arthritis, psoriasis, sort of Crohn's disease, and they get a patent each time they actually find its use for a different indication. Now, of course, they do clinical trials, but they're not per se inventing anything as the patent system is supposed to require you to do. And so what AbbVie was able to do was basically when their main patent, which is your primary patent, was supposed to come off in 2016, supposed to expire. Well, what they did, they filed several hundred more patents. In fact, we counted, they'd filed about 313, of which they'd been granted over 160. There were probably more, but that's the ones we could identify. It's a very opaque system. The US Patent Office likes to say they publish all these applications, but if you're not a chemist or biologist or anybody who's versed in the legal nuances of this, you have no chance of finding what these patents are. And this is part of the job that we try and bring to the conversation. And with all those patents, they were able to prolong their period of monopoly by 7 years before competition could come in. And as you see in that graphic there, the cerise pink part, the price almost doubled in that period of extension. And that is where they made most of their money. They made actually in revenue $140 billion by some accounts. And this is really what is driving, I think, the financialized pharmaceutical system. The patent system is a key tool that allows companies to use, again, that language of innovation. We're improving with this, but really what it is driving revenue. And our patent system, the bar for getting a patent slip over the years. And neoliberalism has actually made that much more easier to do these days than it was like maybe in the 60s and 70s. I think all this started changing in the 70s. And it was deliberately to drive investment, which is really a way of companies getting more back for what they're doing less of these days, is actually doing real R&D. The next slide, please, Jessica. So what does that mean in terms of the longer I can draw out my patent protection, what does it mean in terms of real money? Well, here's just some figures on some drugs. If you look at Humira, just every day of extra exclusivity I get for a patent, that's $47.5 million a day. Um, it's this is what we're looking at. Every day counts. This is why they spend hours in court litigating. As somebody, as a lawyer who's done all this, you're always writing things up in a way so that you can extract the maximum amount of protection. And that's what the patent system has become. It's become something that is very much one of the ultimate weapons in financialization. Next slide, please, Jessica. And I just want to use this slide. This was actually from a House oversight investigation. It was a House Oversight Committee investigation back when the Democrats were holding the House, and I actually did testify in one of the actually investigations into AbbVie, which is the proprietor of Humira. And this was actually taken from documents that were subpoenaed from McKinsey. McKinsey was advising AbbVie on how they could build out all their patents in order to prolong protection to keep competition at bay. And as you see in the last sort of third of this slide, they were offering iPads and laptops to gain ideas of how they could actually come up with patent ideas. And this is how they amassed all these patent ideas that were then used to build those 7 extra years of protection. So it is a deliberate strategy that makes then we, especially communities of color who can't even already afford many of the drugs, we're left out of the system. And it's deliberately designed to maximize wealth and not health. And so I use that as a sort of a stepping stone into the GLP conversation, because the GLPs are basically a sort of even grander version of what is going on with AbbVie. Next slide, please, Jessica. So this is what we see. This is a typical, what we call a patent landscape. What we do is we will do all these iterative searches to find out all the patents that cover a particular drug. And so this is why I asked the question of how many patents do you think cover a drug? So here's all the different types of things that companies will file for and get patents. And you'll see that line 2026 is typically where the main patent should expire. That is when the drug should be available for generic competition. But in the wisdom of our policymakers back in the 80s, and this is why I refer back to neoliberalism, when a lot of this was all crafted in terms of US policymaking, they, in their wisdom, and it was pushed by the industry, said, well, basically, in order to compensate companies for delays in regulatory approval, we're going to give you an extra 5 years of patent protection. It's called patent term extension. So basically, instead of Novo Nordisk's semaglutide product, which is the Wegovy, Rybelsus, and Ozempic, coming off patent in 2026 next year, like in many countries in the world, we in the US will have to wait till 2031 at least because of this patent term extension. And by our calculation, just those 5 years could potentially earn Novo Nordisk $166 billion in revenue. That's more than what most companies make in over 2 decades. And that's not even counting all the other patents that they have amassed that could potentially extend protection beyond that. And what is even more interesting is, and this is why I use the term lifecycle management, is Wegovy, Rybelsus, Ozempic, they all use the same active ingredient, which is called semaglutide. But what they've been able to do is spin off all these different products by changing a slight dosage, for example, for Wegovy, and using it for obesity. It's virtually the same drug, essentially. But what they've done is they've adjusted the dosage, and they get more patents, and they get more longer protection. So we don't even know when we're going to see entry of generics for Wegovy. Some are predicting probably around 2034, 35. So that means more revenue coming in. And these drugs, they're like a Swiss Army knife. There are so many potential uses, as I was talking about with Humira, where you identify different uses of this drug. I mean, they're talking about testing it for people's alcohol addictions. I mean, there was a New York Times article talking about drug addictions and people actually using these drugs to try and fight off drug addiction. So there's all these possibilities, and these are all going to be sort of turned into revenue building sort of opportunities for companies. They're not inventing a new drug per se. What they're doing is they're saying, well, how can I maintain this life cycle? And that is part of the financialized playbook. Next slide, please. And what we commonly hear in these conversations, especially when you're dealing with policymakers or you're having the drug industry, they're saying, well, we have to do this to justify our R&D expenses and make the ROI, the return on investment. Well, as people like Victor Roy have shown in his work, they're spending more on share buybacks and dividends than they often are on R&D. And Novo Nordisk is certainly in that bracket. They have a greater spend, I think it's 41% on share buybacks than actually on R&D. Similarly, Lilly's moving in that direction. These other blue dots are other companies, and you can see most people are on the actual high spend on shareholder enrichment than they are actually on R&D, which is what they say to justify their sort of prices and this patenting activity. And I think that's, again, there's a different rub there in terms of this idea that all R&D is new and what have you, and therefore justifies a patent. I mean, I'm not going to dig into that too much, but that is what the patent system has become. They use this loose term innovation to give more monopoly power, and then they justify it by saying we're spending on R&D. And if you look at the language over the last 40 years, I mean, I don't know if anyone's ever used the Google tool where you track words and the usage, you'll see that the term innovation has actually increased since the late 1970s, and the word invention has gone down. And that's actually the language of neoliberalism. And that is very much tied with financialization. And so this is why I feel like a person out there in the cold always saying that don't use the word innovation, because what you're doing is you're actually playing exactly into the hands of the pharmaceutical industry, because that's the language that they want you to use. And so, yeah, I know these all sound like semantics, but it is, it's culture, and culture shapes how we think and how we receive our understanding of issues like this. And so when we look at what this all means, it's like some of these drugs are going to earn more in their first 5 years than some of the best blockbuster drugs that you probably are aware of. The other word is invention. So when you think about the history of the patent system, the language of invention was what really was that used to drive the sort of the meaning of the patent system. There are standards to say, well, I invented something. It was all invention. But as neoliberalism took hold and financialization took hold, the word innovation started to creep in. And that has actually changed the sort of parameters of what is deserved of a patent, at least by my understanding. And so what does that mean? It means I can actually keep tweaking a drug, claiming it's new, and I call this perpetual novelty. There are these standards in patents where you have to show something's novel. It has to be something that's not obvious to someone in that field. But if you're using the innovation framework, then everything is always novel. Because if I improve something, even though I'm using knowledge that is well known, I get a patent. And that means what these drug companies are doing is they're constantly recycling this existing knowledge, but justifying under the language of innovation, R&D, which has become this, because they want to drive investment. And so what it means, it allows them to recycle their power and stay in a strong position, which blocks competition, which basically allows them to shape the market the way they want. And you think about some of these drugs, I mean, these 5 drugs, the Eli Lilly drugs of Mounjaro, Zepbound, and the semaglutide-based drugs of GLPs, that's Ozempic, Wegovy, and Rybelsus. We estimated, these 5 products will generate nearly double the US revenue than the iPhone did in its first 10 years. That's 470 billion compared to 260 billion. So just think about it. We're talking an electric gadget or a phone, which has its, uses, but here we're talking health. And this is a system that we are operating under. And the patent system is a huge driver of this. I'm not saying it's the sole driver, but there's a number of other issues involved. But this is what it has become. And when you compare the figures, these potential figures compared to Humira, which was the best-selling drug until Keytruda surpassed it, and now these GLPs, Humira earned 4 billion in its first 5 years. Viagra, 7 billion. I mean, I don't know if any of you are old enough to remember the Viagra days and the adverts that used to, it was a cultural moment. Well, GLPs are a cultural moment. But you see all the adverts on TV. It's kind of the issue. And just as Alexander had mentioned, the when we look at the structural racism and how it impacts particularly Black Americans, uh, nearly half of Black Americans are living with obesity. Of 60% of them are Black women, and and the Black adults are tw nearly twice as likely as their white counterparts to have diagnosed diabetes. But the accessibility to these drugs, because these GLPs were originally for diabetes, is going to be proving very difficult. And so, with price tags of $1,000, it's these are the communities that are being left behind. I think what's really interesting, and my colleague Aaron, who I'll ask to jump in if Aaron helped do a lot of the research behind this, and he can add more to it. But one thing that struck me was even where coverage exists, sort of when coverage is supposed to be uniform or sort of across a section like sort of the Veterans Health Administration system, Black veterans had 26 to 36% lower odds of receiving GLP-1 prescriptions than white veterans. So that's even in a more uniform sort of base system. So one can only imagine what is happening in the sort of broader marketplace. Next slide, please, Jessica. So I just want to kind of just wrap this up by sort of, first of all, the first point I want to make is don't buy into this narrative because our policymakers, our economists will always say, yeah, the US we've become more inventive over time. No, we've only become more quote unquote inventive is because the pound system has become abused. And the language of innovation and financialization has driven that. I mean, can you imagine in 155 years between 1836 and 1991, there was 5 million patents that were issued in the United States. And then in just 30 years, we issued the next 6 million. Did we become more inventive all of a sudden? I mean, some might argue, yes, technology moves faster, sure, but it's not all new. But I think that's an economic model that has been created. And I don't want to get into the geopolitics of this, but there's a whole bunch of reasons behind it. The next slide, please. And so I just want to use this as a sort of contrasting, but it's the same story, but just in different locations. And here's a story that ran in the New York Times talking about the very things we've been saying about the lack of availability of GLPs. These rich Upper East Side New Yorkers are getting the drug twice as many as people in Brooklyn who need need it for diabetes. Um, and then I use this story because I've worked in India and around the world on this issue. And when I think about what I've seen across what's in the United States and in India, in countries in Africa, the patent system, the economics that drive neoliberalism that drives it, is essentially a new form of racial capitalism. And I think we have to say that. I know it's a tough thing to say because there's so much more in racial capitalism, but just from my understanding and watching through it, it's just taken on a new form. It's more nuanced. It's not as obvious. It's got different aspects to it. Because when I look at this quote from Marin Dekkers, who was the Bayer CEO, so this was an issue in India, where India was trying to get hold of a cancer drug, Nexvar. And what they did was they decided to do a government intervention, what they call a compulsory license, where basically the government intervenes and gives a license to generics to make cheaper versions. This drug was being charged at $65,000 in India. Anybody who knows sort of the level of incomes in India. And basically, Bayer said when they were in court, they said, well, it's reasonably affordable. And then in a call, I think it was a investor call, the CEO said that they did not develop the medicine for Indians. We developed it for Western patients who can afford it. And I think that story is the same here in the United States. And that is how the pharmaceutical industry works. When it talks about markets, it's only talking about the people who can pay, the people who can't. So I'll just leave it there. Thanks.
Thank you. That was amazing. Just a ton of information that we could break apart any piece of it and just probably spend just days and days discussing. Um, so I want to invite both Tahir and Alexander to sort of just think about, just want you both mentioned GLP-1s and the lack of accessibility for marginalized and BIPOC communities. And I just am wondering if you could speak more to like how both of your organizations are actually trying to address that inequity. Where is the work happening and what should we be thinking about it?
Go.
Do you want to take that first here?
Yeah. Yeah. Oh no, do you want to go, Alex,
Oh,
first?
I can go first. Oh, yeah,
Yeah,
yeah, I can go
no.
first, whichever
Yeah, please,
works.
Alexander. Yeah.
Yeah, no, of course. So we primarily focus on upstream solutions to make GLP-1s and all medications more affordable, specifically advocating for pharmaceutical patent reform, just to allow patients to have access to more affordable generics. And this is because generics, can provide savings of up to 85%, which is life-changing, for our community, which again, experiences some of the highest rates of poverty when compared to all other age groups. Um, and part of how this is done is kind of really tackling, a lot of the anti-competitive behavior that a lot of big name manufacturers will engage in, including tactics like patent thicketing, which is a lot of like what Tahir was describing, just filing all of these different webs of patents to have, legal recourse to then just sue these generic manufacturers, either to block them from, bringing their product into market, or even to just drain their resources entirely, so that the incentive to create these cheap, these affordable alternatives, kind of just goes away. As well as other different behaviors like product hopping, pay for delay agreements, which are all just like different forms of anti-competitive behavior that really, really is just intended to prevent generics from entering the market. Um, so our advocacy has been focusing on promoting legislation as well as regulatory action surrounding these different issues, primarily through sharing patient stories. We're an organization that's founded by and run entirely by young adults living with chronic and rare conditions. So we're really able to talk about our own experiences and really connect, the humanity of our experiences to, these major policy issues. Um, yeah, and we're really, really just trying to work hard, to really shift the focus of this conversation, away from profits of large manufacturers, and ideas of expanding the GDP, et cetera, but really, really reshifting the focus to what these medications are actually intended for. And, they're intended for people and patients and, intended so that we can continue to survive. So, that's our main focus within this tech advocacy.
Yeah, and I would just repeat what Alexander says, and for us, because we've come at it in different angles. We've, as an organization, have actually challenged many of these patents at the US Patent and Trademark Office. We've done it around the world in order to try and price open the space so that competition can enter, so that brings prices lower. I mean, statistically, it shows the FDA did a study that if you can get six generic competitors in on a product, the price drops by up to 90%, which is staggering when you think about it. And so that's the we've tried that from trying to price over open the sort of patent space. But what we realize in the United States, at least, there's a lack of understanding of the role that patents play. And I think our job has been really to start getting that more accessible to people in the field. And I know Saqib and I talked about this the other day, is how do we get this, how do we get people to understand and become educated around the role that patents play in their accessibility to medicines. And so we've done a lot of education, and the advocacy that Alexander's talking about, we do it both at the Hill level, because that's where legislation gets shifted or not. And also, but most importantly, is getting folk in the media. So I think if, over the last 6, 7 years that we've been doing this work here in the United States, I believe now that the media has started to understand. And I think COVID helped as well, because there was a lot of issues of intellectual property and patents that prevented vaccines getting to other places in the world, but also kind of really reflected back on the drug pricing conversations here and the roles that patents play. So that's a lot of the work that we've been trying to do, is research, advocacy, education around the issue, so that more and more people become empowered, and that this is not a subject that is only for experts and technocrats, which is what they want it to be. But everyone can advocate, and people such as Alexander and other patient groups that we have worked with And something that we learned actually, the work we did in India during the HIV epidemic, was that we had patients living with HIV going to the patent office and actually saying that this is costing my life. And it was so powerful. And I think the more we can build that up, particularly in the BIPOC communities, to say that don't believe the narratives that you get taught that, oh, innovation's great. I'm not trying to dispel there needs to be R&D, but don't get suckered into that. That is not for the benefit of you. That is for the benefit of these companies' bottom lines. So it's changing the narrative. I think that's a lot of narrative shaping work that we've been trying to do. And I just wanted to, sorry if I may, just I don't know if Aaron had anything to add to the figures that I'd given. So Aaron is a colleague who did a lot of work on the research that we've been doing. I just thought it might, if he may have a little bit more sort of, if I may ask him to sort of add to anything I may have missed.
Yeah, sure. I guess a few things come to mind. And picking up, I think on a point that you made is that um, there are obviously different sort of levels and places where we see some of the sort of structural racism like unveiled with around these GLP meds. And I think one where there's you mentioned the VA, right, is a system that in theory there should be equal access amongst. But there are actually differential prescribing patterns, and we see that play out even more broadly. There was a pretty seminal study that was published last year in the New England Journal of Medicine. Right? So this is obviously not some small niche journal that showed that basically looking across both diabetes and obesity, that basically white patients were 3 to 4 times, right? That's 300 to 400% more likely than black patients to be prescribed a GLP-1 for either obesity or diabetes. So I think just to underscore that point that there are these sort of very structural prescribing patterns and how these access disparities end up playing out as well is an important one. Um, and then, I think another one that comes to mind too is when you think, I guess you pull back a little bit more and you think about the structural inequities and the case particularly around Medicaid, I think is one worth just sort of shining a little bit of a spotlight on. And in essence, that, these effectively Medicaid restrictions have really shut out millions of low income and disproportionately Black and Latino patients from access to the GLP-1 meds. I think as of now, there are only 13 states that actually cover GLPs um, for for any categorization. And most often, even if that is for obesity, it requires a specific comorbidity with it. So there's very limited access to these drugs, arguably in the population that would benefit from and need them most. So and then you'll look at sort of wealthier, right, sort of private insurance patients that have generally far fewer barriers and far more ease in getting these drugs particularly for obesity. And so it really, yeah, I think it really just underscores the fact that we're living in very much a sort of two-tier system that exists here. Uh, and Medicaid really is a place where there could be tremendous benefit for a lot of folks, and instead it sort of has become the area that really is what's in effect driving a lot of the disparities in access to these meds.
Thank
Thank
you
you.
for sharing that. Yeah. And your example, both of you had mentioned the VA example where all things being equal, race really is determinative of like who gets what drugs and what type of care. And I think, Alexander, you used the phrase medical gaslighting. So I'm just curious if you if any of you work with providers on any of this, because it's like there's obviously grassroots with patients and then grass tops on the hill and whatnot. But is there any sort of education with providers on how to treat patients differently? Maybe not. That might be out of the scope.
Yeah, so one of our big wings that we have in our organization is our peer support wing. So we've done a lot of more work with like patients themselves on how to navigate, just different hostile experiences or interactions they may have with providers, as well as just like having an open space to vent and be able to talk to other community members about their experiences and just, be a better patient advocate for yourself. But as an organization, we have interacted and partnered with different physician-led groups who are truly wanting an equitable healthcare system. And I think really with this issue, it's really important to, support those empathetic physicians who really want to take on these different issues. Because it's really something that like physicians will have to work with one another to help amplify these issues and repair failures that are occurring within provider and patient relationship. I don't know if you wanted to add anything to here.
Right. I don't know if folks have questions. Thank you very much. Do folks have questions? Please just come off of mute. If you're shy, you can drop your question in the chat.
I had a good question. This is Victor. About the timeline. This is great presentations and learned a lot. And the timeline around the 2026 with semaglutide coming off patent. Like, do you see any opportunities because of that? Given that, like as you described it, it's kind of like the base for everything else. And seems like there could be interesting kind of like organizing and policy response because of that in this moment. And I'm just curious if what you see in terms of the landscape.
It's a great question, Victor. Interestingly, Novo Nordisk supposedly, we don't know how it's going to play out, dropped the ball in Canada, and they didn't actually renew that particular patent in Canada. So no one knows why. So in Canada, they're going to get supposedly this generic version. It should be available much sooner than it should have been. So I don't know if you want to know if anybody who needs the drug is going to go flood it, going across the border, but having spoken to some GLP-1 community advocates, we've been using that as a basis to rally around, and sort of because there may be some state laws that could bring in generics. I mean, I know I was speaking to somebody in Florida about this, and they have some state. So there are areas to do advocacy around. I mean, the other thing is, that underlying pattern that you were just highlighting. In India, it's supposed to come off, and already we're seeing movement. In Brazil, it's supposed to come off. So we're going to see a lot of other countries starting getting it. But the US, because of the way it set its system up, because of that extension and all the other patents that may come into play, and we know that some parties have settled with Novo Nordisk to not come in at least until 2032. So we still have to wait until then to come in because of all the patent games to become finalized. There's no guarantee that they'll come in 2032 either, because no one knows what that contract looks like or that agreement. So I think with other countries perhaps making it become more available, I think that's a good point of advocacy to show like, well, generics are coming in way much sooner in a lot of other countries. Why aren't we getting it here? But also, what it is, it's just to add from a more technical point of view on the patent side, we're doing a lot of work around trying to say we need to roll back this patent term extension. I don't think the people who designed it back in the 80s, which was a law called Hatch-Waxman, which gave this trade-off where generics could come into the market by challenging patents, but in return, companies got these extensions and what have you. I don't think anyone foresaw that, or maybe they did, that you would have blockbusters that were earning billions in revenue. That already, even when this drug is supposed to expire, the patent is supposed to expire in 2026, they've earned billions in revenue, but now they're going to earn 166 billion more by some estimates in just in 5 years extra. I don't know if that was ever the intention of that particular provision. Perhaps it was, because what I've learned in policy making is they say that it's not going to be as deleterious as they claim, but then it turns out that's exactly what they wanted to happen. So.
Other questions? Comments?
I would probably maybe I just sort of elaborate on some of the work that I think one, and I think Victor is probably more familiar with this than I am. One area that people are pushing on is bringing the public option into the pharmaceutical space. So they're actually public production of pharmaceuticals. I know we've seen that with sort of the California insulin production, and I know I was at a recent event which Victor was at as well, where New York is also trying to look at ways to do produce insulin for the public good. That would mean that yeah, there's production for what we might call generic products, but things that are under patent, how do we get public production for that? And there's been some work around this by people such as Dana Brown, Chris Morton, um, that really think about how do we change the landscape of the pharmaceutical industry that we're not just reliant on the private financialized business model. And I think if we could get some of these public good options off the ground, people might start to see, well, actually, this is a lot better. And maybe they'll start demanding that in other spaces. Maybe that's the way. There's a lot of work there I think is very fertile. That could be a very interesting area in terms of solving some of these issues. And just one other thing, as we're just doing another report on this as a follow up to our previous GLP-1 report, is I think a fundamental part of this is I imagine everyone's familiar with the term regulatory capture, which is basically how legislative body, decision-making bodies, the administrative agencies like the U.S. Patent and Trademark Office and the FDA, which are governing or supposed to regulate these systems, are essentially captured by industry. And until we can actually undo that and disentangle that, we're always going to be in this cycle where they have the power and the monopoly power being constantly presented under the guise of quote unquote innovation policies and what have you. And I think those are areas where we need to really do a lot of advocacy work, which is what we are trying to do, is trying to bring light on how the sort of administrative state is not functioning in a way for the public good.
Saket?
Yeah, so first of all, thanks so much to both of you. This has been so informative and so rich. One question I have, Alexander, like it was very, very powerful to sort of hear you share your personal story, and I'm curious about, how impactful are like our patient stories in driving systems change.
Yeah, well, thank you for that. I mean, advocating on the behalf of yourself or your community can feel hard at times, due to the vulnerable nature of sharing, the trauma that we're experiencing, dealing with our conditions. However, sharing these stories are crucial to get policymakers to understand the human impact of these policies. I mean, I think people, policymakers can get lost in the weeds and view other, issues, like the economy again, or like GDP or et cetera, or even the innovation arguments, but not actually look at the full picture, the real picture, like the on the ground picture of patients who are actually being affected by these different policies. Um, and like some of the best feedback that we receive from congressional staff or government officials we've interacted with is, wow, it's incredible to hear from an actual patient, on these issues rather than a lobbyist, like it's like so impactful for them to hear that because I think again, it just really connects, the humanity, of these issues. So it's super, super important.
I would just echo from, I mean, as a not as a patient, but as somebody who's been around and worked with patient groups, they are the most powerful voices, and they should be at the front of these conversations. And we've always believed that, we're just lawyers in the background trying to sort of help people understand what's going on. But the most powerful advocacy I've seen is when patients take that information. And just to give an example of this sort of regular capture space, a couple of years ago, there was a USPTO, that's the US Patent and Trademark Office, an FDA listening session. And for the first time in my experience, there were as many patients in the room as there were pharmaceutical representatives. And that for me was powerful because then the narratives just shifted. And it wasn't that because these rooms are usually just full of industry representatives and they get to, have their way. but to have patient voices there, speaking to their experiences, speaking to the difficulties they encounter, it changes the setting. And it's the thing that we want to do with this work as our generation patient and other groups we work with. How do we get more and more people both understanding the issues and advocating for themselves in these spaces? And I think that's the goal.
Tori, did you have a question?
I do. Thank you both. One, and I don't know how quick this question really is, and might depend on your answer. But beyond sort of those, the comment made about prescribing patterns, how else does structural racism show up? And can you speak to that a bit more? Because I'm really interested in sort of the specific sort of components where you see structural racism appear in this work.
I don't know, Aaron, if you have anything that you've found in your research apart from what you've said already, or
Yeah, I guess if a couple of things come to mind around this, and where I think the structural racism sort of plays out a bit more. I think one is it can kind of be considered around these like the geographic and kind of socioeconomic segregation areas too, right? And particularly when there were shortages of GLP-1 meds, right? Which there really aren't anymore. But in those days when there are sort of these, pharmacy deserts that exist, and often in sort of lower income and communities of color neighborhoods, that their obviously rates and their studies that have specific figures. I don't leap to mind right now, but there was real evidence that showed that as a result of that, right, it's not just about the cost of the meds, but it's really about where the supply of them flows as well, and which sort of neighborhoods or communities get prioritized for where these products are actually even available and stocked. So, so I think we see it at that level as well, right? And sort of in addition to the prescriber sort of layer, and if you call it kind of the so that yeah, I guess that's one that leaps to mind.
yeah, and I think that the New York Times story is a good example of that, where you see Upper East Side folk getting access to the drug much quicker, and not in the communities that are really needing it, where there's a higher rate of diabetes. Um, and that's because of pricing structure, that's because of availability, prescribing cultures, and all those things. So it's a factor, it's a bunch of components. But then at the on the economic side, at least from my perspective, is I think the market is set up that way. Is basically is about where can we drive the most revenue. It's not how many people can we treat, it's how can we meet the numbers. And I think that factors in. So it starts there, and then it comes right through, it cascades right through the system. So this is why I personally, and I'm not saying I'm an expert on this, but I feel, you have to start with the question of our economic systems that drive this, and how then it creates the structural racism that comes out of it. So there's the beginning, and then there's the outcomes, and the way the system gets structured in terms of how the drugs get made available. But the economic model underlying all this is it's not to treat everyone as a member of the market. It's like those who can pay.
Thank you. Yeah, I was just interested in because I'm hearing that there's a huge, there's a I'm hearing a huge sort of emphasis on class and income. Um, and I guess that's really, obviously intertwined with the component of structural racism. But I was just in my mind, and this is a very, sort of short thought in my mind. I'm like, well, why isn't it most available in the with the people who are most obese, right? Who could actually, where we can actually see greater change, in that sort of community to actually see if it really works. The most diabetic or the most obese to see
Yeah.
if it really works, right? And so that's where I'm sort of like, colliding there with that idea.
I mean, that would be the sort of logical question or approach, right? But the markets aren't logical. I think, they're not interested in logic. They're interested in, I mean, just look at what happened with COVID and the mRNA vaccine, Moderna. The Moderna CEO said, "We treat our vaccine like a Louis Vuitton bag." Um, and that pretty much, in a way, captures how these products are. They're luxury goods. They're not actually health, for everyone. And Aaron knows this, and Victor unfortunately has dropped off, but he knows it as well. He's written a book about it. The hepatitis C, the direct acting antivirals that came out in around 2013. Many people who are incarcerated have hepatitis C, but they didn't get the drugs, and these were potentially curative, but they were the ones who, because they're not deemed important enough, or they're not going to pay the price, and there was a rationing of the drug until only those who had severe liver conditions were at the front of the queue. But basically, it was just such a I mean, it was basically who can pay. That's the first option.
Saqib?
So, one other question I have, so as you think about this work, like what are the challenges about actually doing this work, and do you have thoughts on like potential solutions or alternatives?
I mean, there are a lot of challenges because I don't even know where to start. I would probably start with, first of all, is trying to distill at least the connection between patterns and how the financialized business practices are. Because most people, as I said in my talk, people see patents as a positive because we wouldn't have these medicines if it wasn't for the investment that companies make, and et cetera, et cetera. And I think, of course, we want people to be doing the R&D, but not to be basically using all these tools to essentially get more monopoly out of a system than they should be. And I think one of the hardest part is trying to get that narrative shift, because particularly in the United States, I think, having done this around the world, the United States, its patents are almost like part of the Ten Commandments. It's something that basically is religious almost. And some of the people, our adversaries that we have to come across in this conversation. Oh, I mean, literally, you say a bad word about patents, and you should be sent away to an island. That's how they feel about it. And I think breaking that barrier is still important. I think we've done some of that, as have other organizations like Generation Patient, but we have a long way to go, and we've got to get this to more communities and get this conversation. So I think that's the narrative shift work is still so important. Um, and I think breaking some of the sort of myths around the patent system that the industry has perpetuated, and this the fear factor that, oh, if we take these toys away, we would never get new medicines. All those things have been sort of proven not and factual in many different ways. Um, but I think that from my side at least, that's been the biggest challenge, and we are really in the crosshairs of the powerful industry and the lobbying that goes on. I guess in some ways I hold it as a badge of honor. I-MAK is probably pharmaceutical industry's public enemy number one when it comes to people talking about the patent system. I mean, they built websites about us saying, trying to expose us. I think that's a badge of honor. That means we're doing something right. I don't know, Alexander.
No, I mean, kind of going off of that too, counter messaging is one of our like biggest challenges that we have, specifically from other patient advocacy groups that are completely just pharma funded. So they're basically just pharma front groups with, a name of a specific condition in front of it, or etc. So it's kind of hard to when we're going into meetings and we're talking about these issues and how important patent reform is, to allow us to have access to cheaper generics. And then, we get a counter to that saying, oh, well, this foundation just spoke with us last week and they say something completely different, or they say that oh, patent reform would actually hurt us and that would, cause all these different issues, the whole classic innovation argument, which is a failed argument that they just continue to perpetuate. Um, so I think that's like definitely, one really, really big area. And right now we're actually in the process of creating a toolkit that we can provide to just different congressional staff as well as, other government officials on, how to vet, different groups that are speaking to them, and find out, what are your funding sources, what are, the conflicts of interest that you have that could be steering you to advocate for this very harmful policy that does not support, whatever patient population you're claiming to represent. So,
I'll just add too. I think particularly with the GLP-1s that we're in this sort of interesting moment where these drugs have proven so widely beneficial, right, to such a large swath of population, obviously with obesity in particular, but now with so many additional follow-on indications and uses that we hear about often. I mean, there's some people that say, right, these drugs that will can and should be available, for free to everyone, right? And they have such a benefit that way. These aren't obviously not sort of specialized cancer drugs treating one small sliver. That I think it could be a really interesting moment, and to sort of harken back to the Canada example. I mean, in the coming right in the beginning of next year, we're going to have who knows what the number will be, but are probably $50 to $100 uh, priced generic GLP available just across the border. So I think we're going to see pharma really ramp up the rhetoric on, the sort of the innovation machine and like this, and particularly the safety concerns of around these. But I think there's a real chance for a patient and sort of community-led initiative to really almost demand access for these meds, and particularly that we're seeing right across the border at such low cost and high availability. It's going to be interesting dynamics, and I think, but a good opportunity to I think drive home some of these messages around promoting access.
Lower my hand. Um, and I'm curious about when we talk about access and the generic version of the GLP-1s, thoughts about like Noom, Row, Hers, these sort of, well, I see them as apps, right? So mobile social media apps, they're like, mobile apps that you can get a prescribing doctor to send, right? Generic, what seem to be generic GLP-1s, trizepatide, as I don't know if that's a branch of GLP-1s, right? But semaglutides to your home, right? Been made really popular recently with Serena Williams taking them, right? Being an ambassador of Roe. To me, that looks like increased access, right? So for $100 a month, you can get a 2.5 vial of semaglutide delivered to your door, right? So I'm just curious about that. And in addition to not needing insurance or not needing to go to a doctor's office to get it, right? So to me, that looks like generic and increased access. So what are the thoughts on that? Or is that not sort of the same as like your Ozempic, your Mounjaro, your Wegovy?
I mean, I'm sure Aaron has some thoughts on this as well, but I'll just start. So I think I don't know. I haven't studied Roe particularly, but I've seen the adverts. I mean, Charles Barkley as well, um, sticking a needle in himself. But a lot of these are compounding agencies, so they're not actually FDA approved. So
Hmm.
what they do is they get the ingredients and they kind of self mix it. And so because there was a shortage, certainly for the semaglutide based drugs, the FDA allowed this compounding to happen because there was a real shortage. I mean, there still is. But now they've started to clamp down. They've stopped that use now, I think. And so basically now what you have is Novo Nordisk and Eli Lilly now going around starting legal actions against these compounding agent things. So they're not correctly called generics. They're called compounding things. I don't know if Roe is the same, Aaron. I don't know if you've looked into that, but
It
it
is.
looks like a compounding for me. So they're not FDA approved. And so this is where as Aaron says, people are saying, oh, well, they're not approved, they could be unsafe. And pharma historically has always done that, even with generics, officially approved generic drugs. They've always tried to create a narrative that they're unsafe. And I mean, that used to happen with the HIV medicines, and it just thankfully it never stuck. But they're doing that now, and with the FDA now sort of saying compounding is not permitted, supply's enough, which it isn't. They're trying to regain hold of the market. And that's why they're offering all these discounts and these telehealth stuff and what have you. So they're trying to recapture the market that way, and so keeping it all under brand and higher priced, even though they may be seemingly trying to lower the price or do these special adverts. But Aaron, I think you've also looked at this.
Yeah, I mean, I think I think broadly they are. It's sort of a unique aspect in sort of these meds that are so widely applicable to so many people. It's obviously why these platforms like this are so keen on picking up and having some offering of these. And then as Tahir mentioned, right, that sort of interesting little, loophole of sorts around the supply shortage initially that really enabled them to be able to legally, fully legally without any sort of gray area, be able to offer these products for sale. And then, they've kind of drug their feet on and of course, they have an interest in being able to continue doing that as long as possible. So, but I look at these and I think they're, in terms of the, for broad access movements, I think they're generally great initiatives, right? Um, it does really stoke up again, the pharma rhetoric around what's safe and suitable or not. But these, I think, big pharma is going to have a real challenge with this. I mean, they are already with these kind of entities, and I think we'll see even more of that when Canada has even lower cost product that's available. Um, so yeah, it's and just your other point on tirzepatide. So this is interesting, right? So it's like how you mentioned initially. So semaglutide is basically the Novo Nordisk drug. So that's Ozempic and Wegovy. But it's the exact same compound. It's just a higher dose. Wegovy's a higher dose of it. And it's parallel for tirzepatide as the active ingredient in Eli Lilly's Mounjaro and Zepbound. And those are just, Zepbound is just a higher dose of it for obesity indication, but the exact same drug.
So we, as an organization, have a different view just on the compounded GLP ones, just because they aren't FDA approved. So a lot of, the approval that generics would have to go through to show that, they're being produced in the same way as a brand name manufacturer drug, slash, like post-market surveillance and all these other different things to ensure that, if there are adverse reactions, those are being reported by FDA and the public is alerted. That's not the same landscape that's happening with these compounded therapeutics. And while like it is something that is fulfilling, a shortage, we also want to make sure that, the products that we have access to are safe and effective as well, Um, that's a little bit our view of that, but one of like the big issues I would say with like a lot of these like telehealth platforms that are emerging, like Hims and Hers, is for like a lot of the other products that they do sell or do promote are brand name products. They often will not promote a generic. They'll promote the brand name, and often patients are paying more than what they would actually have paid if they had gone to a provider and had found out that there is a generic available for whatever medication that they're seeking. And then the other issue too is there was a recent report that was released by the offices of Senators Durbin, Sanders, Warren, and Welch. It was released this past July, just reviewing all of these different telehealth platforms, including Hims and Hers, as well as so many others. I mean, I feel like now it's like every manufacturer now has their own version of a telehealth platform that ads are now redirecting you to because they just fully just want to, you know, completely remove any risk that whatever provider that a patient is speaking to, may not choose their drug. So this investigation found that, these telehealth platforms are being like run completely by the manufacturer. The providers that are on these telehealth platforms are financially incentivized to prescribe, the high price brand name medications. As well as too, like they were looking at prescription rates, and for some of these platforms, they're having prescription rates of up to 100%, which is just completely unheard of. I mean, even on the lower end, it was like 74%. So I mean, that's like not common, you don't very often, every time you go see, when you see a provider and you talk about whatever condition you may have and whatever prescription you may want, there should be a conversation about, okay, what are the potential side effects? Is this something that is right for me? Is this something that I can afford? Are there cheaper alternatives? With these telehealth platforms, they're just completely removing that and just pushing these products completely onto patients.
And I think that that probably also speaks to sort of as a way of resolving what is really an upstream problem. We're getting all these other sideshows, and we're not actually fixing the problem in terms of its source, right? Um, and yeah, people might call, oh, these are innovative business models. Sure, I mean, I know people who generally have used these compounding products, and now that they've been sort of cut off, they're struggling, particularly GLP-1 patients. All of a sudden they're having to try and buy it from somewhere else. But I think it speaks to the system itself that we that you get these other spin-offs and these compounding models, which may work or may not. But I get the safety thing, but really it takes us all further away from actually resolving the underlying issues that cause these problems in the first place. Um,
Absolutely. I agree with that as well. I mean, because I mean, the patent system has created a very real access issue, and I think that a lot of patients are very willing to take those risks if it is a cheaper alternative. But we want to make sure that those cheaper alternatives are also safe and effective. So we really got to get to the root of the issue, and not create that landscape.
right. So people are not forced into that situation.
Exactly.
And I also think that they're a cheaper alternative, but not cheap, right? They might be cheaper than Wegovy, Ozempic, but they're still not cheap, even on these different telehealth platforms, right? So there's also that. And I just, in our last couple of minutes here, do we see sort of like those telehealth platforms and they're sort of popping up as being a product of the overall sort of conversation of financialization?
I imagine so. I mean, I think the business models will be all shifting. It's the financial sector is pretty much in every it's got a foothold in every of these ventures. So it will become that'll be their driving force as well. Because at the end of the day, they're interested in capturing markets, and we've had some of these uh compounding agencies, whatever, speak to us saying, hey, we're doing advocacy around this to try and get out, and they want us to kind of work with them. And we're like, we don't speak for anyone in the industry. We're just trying to do it from a public interest perspective. So they're using whatever leverage they can do to kind of achieve their goals. So I imagine, they've got investors that they want to appease as well.
Okay, well, thank you very much, everybody. Uh, this has been so informative, such a rich discussion. Thank you so much, especially to Alexander, Tahir, and Aaron for all the work y'all did on uh, both preparing this as well as the research. Um, Tahir, is the research that y'all have written, is it available?
Yeah,
Or
I'll
not
just
yet?
pop it in the chat. Uh, it's here we go. So this is the research we put out in April this year. We're going to be doing a webinar at the beginning of next year around this work and anything we've done since then, which will speak to some of the newer GLPs that are coming into the market, which are in the pipeline. So we'll send out a invitation to anybody who's on this conversation if they want to continue it and follow what's going on. So that'll be probably sometime mid-January next year. And then
Excellent.
next week, there's a webinar that I said on the survey results that I mentioned. Again, if people are interested, because there'll be Senator Walsh will be part of that conversation, and so we'll be talking about some of these issues.
That's great. So yeah, thank you all so much. Just a reminder, our next Lunch and Learn session is going to be on December 11th at 1 p.m. Eastern. We'll send around the registration link is in the chat if you want to register for that one. And we will be following up with you all. So thanks again so much, everybody. Really informative, really helpful, and looking forward to being in touch.
Yeah, thanks for the Acre team for holding this session, and Alexander for coming in last minute at my request. Thank you.
Yes, no, thank you to everyone on this call. And also thank you so much for always amplifying our voice here. We are so grateful for I-MAK and just the amazing work you do. And it really, really helps to fuel our policy, you know. So I'm really, really very honored and happy to be here.